My name is Megan Haupt. I am Chief of Staff with the National Association of State Mental Health Program Directors. This is episode 214 of the Crisis Jam, and we are going to have DeafLEAD present on videophone services for crisis care, and we'll have Brittany Noschese as well as Olivia Stein, who are both from DeafLEAD, and just absolutely thrilled that they'll be presenting. Let's go to the next slide. And the Crisis Jam has had over 500 unique speakers. And gosh, as you know, 214 episodes, and then here they are listed in terms of the people that have presented so far. And if you have a hot topic idea, please let us know. In terms of, hot topics, get them in. We have lots ahead of us as well. We just got a question, will this be available as a recorded session? Yes, and we will talk more about that in a moment. There are lots of ways that, to access the Crisis Jam. And so we have live streaming. And first, of course, we prefer that you register and experience a Crisis Jam in Zoom. You can interact in the chat and ask questions that way and react. There's also the live streaming on YouTube in case there's an issue with a Zoom account. And you can also even look at episodes afterwards on the Crisis Talk website. So just be aware of that opportunity, lots of opportunities, and lots of people do follow up and even watch again. So here are some of the past episodes we've had. We're incorporating different formats, which I'm really excited about. There's the debate format, fireside chats, which is more in that orange, and you can see the word debate going across. There's also the live and on location, which are in those light blue, and also more of the standard format, but still amazing format that are in yellow there. So just know kind of how it's categorized when you go and look at past videos. All right, next slide. Wonderful. And we have lots of debates coming up. And the debates have been so helpful because oftentimes, one, they're interactive. Two, you get to hear lots of different sides and perspectives. And so they move the issue forward in some way in terms of the thought and leadership. So one of the first debates we had was on whether or not AI should be the future of crisis care. And we always poll the audience about what their thoughts were after the debate, pre-debate, after the debate, the debate. And after this debate, about 32% still weren't sure. It was the most common response. Debate 2 was on should mental health care should come with a police car, like a co-responder model. And the most common response was no, 48%. But you can see in the smaller lettering there in the numbers, kind of what the spread was. But no, 48% felt mental health should not come in a police car. The third debate was, they debated we should substitute the word emergency for crisis services. And the most common response was 53% of the audience felt no, we should not substitute the word emergency for crisis. Wait, we should not substitute. Yeah, that's right. Okay. Debate 4 was on peer support specialists should be part of behavioral health crisis care services. This is fascinating because 66% definitely said yes. So you'll see sometimes there's a yes and then a definitely yes. This is a very strong response. The most common response being definitely yes at 66%. That was in December. And then debate 5 was on crisis facilities should take both voluntary and involuntary referrals. This was very interesting because you'll see that the most common response was yes at 36%, but 33% said definitely yes. So that's a very big response as well. All right, and debate 7. You can see we've had a lot of debates. We have a lot ahead of us. They're very interesting. That mobile crisis should always be dispatched by the local 988. Now, the most common response was yes at 36%. What's really important about this is having mobile crisis makes a very, very big difference in terms of whether there is emergency room boarding. If we don't do things differently, then we're going to get the same response. And I will say that Dr. Brian Hepburn, who is the chief executive for NASHPID, kind of challenged the group on that, saying, give this a lot of thought, because if we keep doing things the same way, we're going to have the same result. And we need to move ahead from emergency room boarding, et cetera. All right. And some future debates coming. The next one is May 14th, and it'll be Hannah Wasilowski and Tom Betlak. Hannah is on the affirmative and Tom is on the negative, related to all states should enact legislation that includes a 988 fee. Now, while I say that Tom takes the negative, it's not that Tom takes the negative. He just brings in a lot of different perspectives on that, but Hannah is taking the affirmative on that. That's episode 217. And then a debate after that, debate 8, will be on whether crisis facilities should require parents to stay during a crisis episode. That's going to be June 18th. And this was really neat because Michigan really brought this topic to us. It'll be episode 222. Gwenda Summers will take the affirmative, and we are still working out who would take the negative on that. All right. And debate 9, while we're still working out who will be the affirmative and the negative, it will address coordinating follow-up care and crisis services requires high-tech software solutions. And that's coming July 16th. So you can see we have some great conversations. We also have the live and on location. This was the Huntsman Crisis Care Center in Salt Lake City. That was awesome. And there's that kind of continuum on what crisis services address, and the Huntsman Center, as well as a future live and on location one that we'll go over in a minute. These really are not inpatient crisis centers. They have crisis beds, they have recliners. It's really observation. So it's not inpatient, and that's a very important distinction here. And June 4th, there's the live and on location in Columbus. It's the Franklin County Crisis Care Center, and that will be 60 recliners and 16 inpatient, almost a $60 million community investment. Very similar to the Huntsman Center, so it's so great. All right, I'm going to turn this over to David Covington to do an over-under. David, go ahead.
So, Megan, thank you so much. We've had Who Wants to Be a Millionaire style hot seats most of our crisis jams, but last week we started another over-under, and we're going to continue that tradition this week. We're inspired by Margie Balfour. Now, Megan laid out Dr. Hepburn's challenge. Let's do things differently. Let's look at the way 911 completely transformed how you get an ambulance or a fire truck, and you get it faster and easier. It was complicated. It took us some steps to get there, but when we got there, it made a difference in the terms of speed and response. And as we take that a step further, Dr. Balfour has this great slide. Several of us have taken a step at this data, but no one's done this better than connections. And so our over-under today, and we're just going to do this in the chat and text if we could, is we're going to take these in order. It's last week was a double feature. I think this is a quadruple feature. But she says that when we have a coordinated system that flows and is orchestrated, that 988 crisis and access line might resolve X% over the phone without it going on to a mobile team. What is the number that she says can be resolved over the phone? What percentage of those can be resolved over the phone? We see Gerald Stansberry's putting in 90, get a lot of 90s, 80, 85, 80. So we're all as a community striking in that range. According to Dr. Margie Balfour's slide, 80% of those incoming calls to 988 or a state crisis and access line can be worked through the support of a caring individual on that call, text, chat. For those that need more and go on to a mobile crisis team, that again is the equivalent of that ambulance in the medical emergency world, what percentage of those can be resolved by a clinician, a social worker, a counselor in partnership in a team with a peer support or some kind of technician? Let's see that number. Megan says 60, Abby 75. It's not exactly the same, but it is in that high range of 70%. Let's go on to the facilities. You didn't get enough support with the mobile team. You land up going to one of these observation recliners or a short-term crisis bed. Same question. How many get resolved at that point and return to the community without going on to inpatient or other supports? Again, these are the folks with the highest level needs. The audience is keeping those numbers high. It's not quite as high, but still a phenomenal impact from a recovery standpoint, but also from a cost and a systems deployment standpoint. Further, we'll just go ahead and shoot that. For when we have post-crisis wraparound, Dr. McKeon is always talking about the vital support. He calls it chain of care, but this follow-up really makes a huge difference. Now, Margie has actually, I think Margie is on a plane and unable to jump in audio-wise. She was going to try to jump in the text chat. I don't see her yet, but she's actually transformed this slide into a second generation. And I was hoping to get her feedback on it, Megan. We'll bring her back at another point. But I think one of the changes that you see from the last version to this one is it really focuses on the unnecessary law enforcement, unnecessary hospitalization, unnecessary emergency department involvement that gets dropped out when you have this flow. So again, I thought with Dr. Hepburn's challenge of let's get 988 dispatching mobile crisis, let's get this system working as a flow, and just to show that impact, thanks to Margie Balfour and Connections for their work in this regard.
David, thank you so much. And really appreciate that enhancement and that challenge to the community. We are now going to go to our featured presentation. We are having Olivia Stein, who is Vice President of Programs for DeafLEAD, as well as Brittany. I'm going to go for Noschese. Yeah. So Brittany Noschese, who is Assistant Director of Videophone Crisis Line Services for DeafLEAD. So just so thrilled to have you both. It's such an honor to have you. We know you're very busy. You all are literally taking your time here and having other people cover the lines for you. We understand that, as well as your interpreting team. And so just thank you. We want to really inform the audience of how important this service is and the great work you have done. I will hand this over to you.
All right. Thank you so much, Megan. Truly appreciate that. Really, first thing, I just wanted to reiterate how important we feel it is to be here. We're so honored to be here, given the opportunity to speak on really important topics like this, a topic that we feel truly passionate about, strongly advocate for as well, and we have done that for a long time. Really just want to start with putting a face to the name. So hello, everybody. My name is Olivia Stein. This is how you sign my name. My pronouns are they, them. I'm currently the Vice President of Programs here at DeafLEAD. Wanted to introduce my colleague as well. Brittany, I'll let you take it away.
Hi there. My name is Brittany Noschese. I use she, her pronouns. I'm the Assistant Director of the Videophone Crisis Line, so I'm excited to be here.
Awesome. So we have our two interpreters as well who will be providing voiceover for us today while we're signing. And I wanted to start off with a brief description about our organization, where we come from, and our roles, how those have come to be here at DeafLEAD, how long we've been working here at DeafLEAD. And DeafLEAD itself is a nonprofit organization based in the state of Missouri. It has been in operation for coming up this summer, 30 years. This organization, this has been a long time coming, and for how long it's been here, our focus has been on victims and service for victims for quite a long time. Our services, our service line departments have been in operation for the past few years. And currently within the organization, we have about 12 different departments currently. One of those 12 departments is our Videophone Crisis Line Services Department. One of the other departments that we have the Crisis Interpreting Team. We have the Advocacy and Wellness Team. We have Suicide Prevention Program, Substance Use and Youth Support Program. We have a training team. The list goes on. We have quite a few departments that we've established in our time here in the past few years. And in 30 years of operation, we wanted to recognize our CEO as well, Dr. Stephanie Logan, who has been for a long time a part of the organization just on her own. And so right now, our organization has over 350 employees. We're reaching 400 currently, and it is a very diverse group of identities, cultures, and backgrounds. It's a mix of deaf, hard of hearing, deaf blind, deaf disabled, late deafened, and hearing as well. We have a wide range of employees. So proud to be a part of this organization. So now I want to turn it over to Brittany to talk a little bit more about our Videophone Crisis Line services itself.
Yes, thank you. So as mentioned, we have 12 departments. One of the departments is the Videophone crisis lines. We have two lines, the Deaf Crisis Line, which we call the DCL for short. That was established October of 2017. And this line, the DCL, we engaged with callers who are facing a variety of challenges, who maybe were victims of crimes. And then the second line we have is the 988 Videophone line, was established in September of 2023. We're soon reaching 2 years. Callers to that line are often calling us because they are going through a variety of crises, including suicidal ideation. And so with those two lines being established, when we first had the Deaf Crisis Line, we noticed how important it really was to be able to have a resource specifically for the deaf community. The National Suicide Prevention Lifeline was then converted to the 3-digit number 988 Crisis Suicide Lifeline that happened in 2022. And working with our stakeholders, our partners, we were trying to figure out how we could provide more services to the deaf community. And so we added our 988 Videophone line, and we continued to provide that for our deaf community to support them in a different way. And so DeafLEAD is one of the centers that provides the 988 Videophone. We also have crisis services. There's another center, CCSI, who runs another Videophone crisis line. So two centers. Oftentimes you'll see the deaf community calling it VP 988, ASL 988, 988 VP. And so that's common in the deaf community to maybe apply those names, all meaning the 988 Videophone crisis line. And so we run 365 days a year, 24/7, to include holidays, and callers range of all ages, deaf, hard of hearing callers, individuals who also use ASL as their preferred method of communication, who might not be deaf as well. And so here at DeafLEAD, our crisis counselors, they take 100+ hours of specialized training so that they are able to provide that emotional support, resources, a variety of tools to those callers who are in need and who might need that type of information. 988 VP, as well as the Deaf Crisis Line, we're really here to be able to provide that direct communication access to serve those in the ASL community. Oftentimes, English is not the first language of a deaf individual, their native language, where American Sign Language might be. So we're able to provide access to them in a time of crisis in their native language of American Sign Language. And how you can reach out to us is two different methods. You might be able to go to DeafLEAD's website. We have a platform there that you can click a link to connect, or they can choose a Videophone service company and they can reach out to us directly through their Videophone.
Okay, so with the methods of contact and the ability to, we wanted to take the opportunity to see how the end user would be able to reach out to us. So we'll have a brief clip that will show of what it looks like on our end, as well as methods to reach out to us on the user end. So we have a clip that we'll show here. It's about a minute or so, and then after that clip is finished, we'll elaborate a little bit more on that. So this shows both methods where um, it's on the phone as well as on, a desktop computer, that sort of thing. So that first method that you just saw, that was on a web-based platform. This one here, the second method is what's called our video phone, what that looks like. So contacting through either method, it's the exact same experience. Okay, so that was just an opportunity to get an idea of what those methods look like whenever you reach out to us. Whenever you reach out to us, both lines, whichever one you decide to use, there is a queue where the visitor will be told which line they've reached out to, and it will be communicated that you will be connected to the next available crisis counselor. So Brittany mentioned a little bit about how the Deaf Crisis Line operates, and that was our first crisis line that was established back in 2017 in our organization. This was something that allowed direct communication, and it really serves as a greater role model for our establishment when it came to the 988 video phone itself. So now I want to elaborate a little bit more about why direct communication is important, why that matters to those who are in crisis. So you may already be familiar about video phone services and how that works for chat and text, as well as voice, uh, phone calls. So comparing all of those methods of communication, why is it important to have direct communication in this manner? So if you ask yourself this question, what method of communication matters to you? If you're in a moment of crisis, in a moment of distress, and you're having thoughts of suicide, how would you like to communicate with the person that is providing support? Maybe that could be auditorily, where you're speaking, typing over chat or text, whichever platform you decide to use that way. For many within the deaf community, we are ASL users, and we wanted to recognize that ASL is the primary mode of communication. It is our language. So when it came to resources that were not available for many years prior to this being established, it wasn't, it was accessible, let's say, through a third party. So you'd have an interpreter in the middle with video relay services where they'd be able to reach out to the National Suicide Prevention Lifeline phone number before the 988 video phone was established. That person would be able to sign and dial the 10-digit number that would allow them to reach out to them through the use of an interpreter. However, the language accessibility, that comprehension of culture, that recognition, also the delay in communication being immediate, having an interpreter serve as the go-between the visitor and the crisis counselor, that kind of exacerbated the situation. So what we noticed was, why are so many deaf and hard of hearing individuals not utilizing crisis services? Why did they not utilize that before we had the video phone service? This kind of answers that question. It's that direct communication aspect, that comfort level. So language accessibility is truly important in this regard. It is our primary language, talking about ASL. It's our choice to use that. So having this option of chat, of text, voice call, if they decide to use so, as well as video phone, now we have the capability to kind of choose which one is most comfortable for us. If I prefer this or that, it's great. Before, we didn't have that option. We were more limited to the three. We didn't have the option. Are some deaf individuals who feel pretty comfortable using text, which is great, if that's their preference, rather than using sign language to communicate their feelings. What's most important here is that every person within the deaf community, acknowledging that they are different in their language choices, how they decide to communicate is not one size fits all. Myself, as a person who identifies as deaf, I would prefer to use ASL first in my language choice. Because that's my first language, I'd prefer to use that. However, you may meet another deaf person and they may have a first choice of language. Maybe they decide to use ASL, but they may prefer to use, in the moment of crisis, use text. It's great that they have that resource available. We had that resource lack before this was established. So now we have the luxury of choice, and we're seeing that accessibility increase. Another aspect of this is the emotional connection between the visitor and the crisis counselor. Talking about sign language, we are very expressive in how we use language on our face. You may see myself and my face be a little bit more animated than a person who's just speaking. So when we're needing to connect to a caller who's in crisis, we may be asking them questions. We want to show them that we are taking them seriously. We want to let them know that we're there for them visually. How we communicate that is that they see us. They may be judging our body language, how we're expressing ourselves. That will let them know that I'm a person who's available here for them, ready to provide support, as long as I'm communicating that visually. I'm already communicating that with nonverbal cues, just in my body language and my facial expressions, without even putting my hands up. That's already inculcated in ASL communication. So another thing to consider, why it's so important to have this, trust and comfort is another factor. This person may realize that we're trauma informed, being able to communicate that they're in distress and crisis. It just feels that there's empathy there, and we're able to build trust and comfort in this communication as we're walking them through the process, allowing them to share their own story. And the last thing about this, why it's important, is efficiency. So I mentioned earlier, talked about how effective and maybe not so effective it may be to have three-way party communications, having interpreters that are out in the community, in the VRS sphere. They may not always be trauma informed. They're not always trained in this. And this is not to place blame on the interpreters. It's just a lack of training and education that's not really effective whenever a caller is in need of support in their moment of distress. Oftentimes, interpreters are trained in 911, but when it comes to 988 and emotional support and that aspect, them understanding the crisis that they may be in, the mental health aspect is lacking. So when a person is in crisis or distress, they don't want to call 911, but they need somebody to talk with. Interpreters are not informed and they're not trained on that. So I do want to apply our crisis interpreting team here at DeafLEAD. They are trained in trauma. They're trauma informed. We do have an interpreter. The interpreter who's training for me right now is trained and experienced and knowledgeable in what to expect, what the expectations look like that come with our services, our organization, and the community that we serve. So as I'm signing, I'm wanting efficiency. When I'm communicating this piece to my audience, which is you all, I want to make sure that that's communicated. That's why it's so vital to have interpreters who are trauma informed working within this field. So the next topic I really want to bring to our audience here is about deafness and sign language fluency among our staff and our crisis counselors. What we bring to the table that hearing call centers just aren't able to bring. What's different about us, if you will. So I'll turn this over to Brittany to talk about for just a little bit.
Sure, I'll touch on a few things related to this. One of the biggest things that we notice is that deaf individuals are displaying a lot of nonverbal cues. Again, facial expression, movement of our body adds nuance, not specific words, but context to the communication. So when people call, we might be able to watch their facial expression, their eyebrows are saying a lot, or the actual signs that they're using. If they're in crisis, they might be signing smaller or their sign production looks different. Oftentimes, sometimes they might pause for different reasons. Those little cues help us understand maybe they're not in a safe area or they're in crisis and they can't sign out loud because someone's watching them in the room, or they're grieving or they're feeling fear. We're able to pick up on those cues. So crisis counselors are able to notice those nonverbal cues, and they'll be able to modify what they say back to the caller based on what they're seeing visually. And to make sure that the caller maintains their safety and that the questions are tailored to making sure that they're able to answer and understand the information. Crisis counselors also understand deaf culture, communication preferences and access, nonverbal communication, those identifiable cues that maybe aren't always said with specific words, but being that they're deaf themselves, they understand that in the language. Deaf individuals, not all, but many deaf individuals do prefer to communicate in American Sign Language rather than typing in English. Some of our signs just don't have an equivalent English word. And so oftentimes we might get stumped when we're trying to express ourselves. We might say, and a crisis counselor can see that the visitor is thinking, trying to figure out how to phrase something, and we wouldn't type in chat. And so maybe they can't share something because of the location they're in. It's not safe to share. So our crisis counselors can take note of that. Also, written English doesn't include intonation or feeling. Someone might feel sad, but you would have to explicitly say, I am sad, but it doesn't tell you the depth of sadness or the intensity. English can't convey that, where American Sign Language has that additional information. We can gauge the amount of intensity of sadness, the tone of their signing, whether it's a larger sign, a smaller sign, facial expression, and then the crisis counselor is reacting based on what they're seeing and being able to read. Crisis counselors who are deaf or hard of hearing, who are ASL users, also just have that inherent understanding of deaf culture, the linguistic component, and they're able to interact with callers and be able to modify their language for that caller. If a visitor calls in, the crisis counselor might be giving them a head nod, which signifies to them that we get it, we're listening. Those little cues, nonverbal cues, are also showing our visitors that we're here to support you, we're ready to listen, provide resources, whatever's needed. Another thing is that having direct communication between the crisis counselor and the visitor without the use of an interpreter, even though interpreters are great, there are times that having that third person a part of the conversation creates a delay in a time of urgency. We're trying to pass on information in urgent matters. So having information passed on directly between two people is much faster than going through a third person. Perhaps this person has thoughts of suicide or they're not in a safe area. Just having that direct communication makes a big difference as far as expediency with our callers. And we can see when they're in crisis, they're able to interact with us, and we're able to de-escalate the situation potentially faster and making sure that they are safer, being able to provide the resources that they need. And then having that direct communication access in American Sign Language to be able to receive that help without any barriers. It really does save lives. And it's such the importance, it just highlights the importance of having direct communication. And I'll let Olivia expand on that further.
Yeah, so we're getting pretty close to the wrap up of our presentation. So when we're communicating in ASL, we do have to consider the part of providing a safety assessment during the call. So the term suicide itself is not often exposed to members of our community. It's not often talked about. So whenever we are interacting with our callers, there are some callers who their response, whenever we spell out the term suicide literally, when we have to do our safety assessment, we oftentimes have to, within our language, kind of code switch, if you will, to kind of modify and meet the caller where they are in a way to understand. So we'll kind of tailor our questions for them so that they're able to understand before we continue on with the conversation and kind of meet them where they are at their level. So if I ask somebody, are you having thoughts of suicide and spell that out, maybe they'll ask, I don't know what that term means. So have you had thoughts about maybe ending your life? So we're able to tailor and really meet those individuals where they are at their language, their comprehension of what we're talking about. And we're able to see that in action. Just having that visual modality, we're able to see their environment. We're able to see the context that they're in, where they're at, what struggles they may have. We may be able to actually see it. So as we're doing the risk assessment, safety assessment, we're able to catch nonverbal cues as well from them. So that's really been effective in our communication, how we're able to communicate those things. So I just wanted to share those closing thoughts whenever 988 VP was first established back in September of 23. We're coming up on the 2-year anniversary this year. We've already arrived at over 40,000 calls reached out to us on our line. And that's tremendous. That's a large number. It's effective. It shows the success and the acknowledgement of the need in our community for our line, for the resources that we provide. We are available to our community as an option to choose from if they need somebody to talk to. Brittany, would you like to share any closing thoughts before we turn it over to the roundtable?
Sure. Yes, when individuals are able to receive services in ASL, we're able to create that safe space where they feel heard and understood, giving that full access to them between crisis counselor and visitor.
Okay. So wanted to thank you all for having us. Would like to turn it over to our roundtable for their discussion.
Mute. Thank you so much, Olivia and Brittany. What an incredible presentation and context. Let's go to Dr. Stephanie Logan, who is CEO at DeafLEAD. Dr. Logan, would love to know your perspective and anything you'd like to add to this presentation. We know your leadership has been extraordinary. Please go ahead.
Yeah, I mean, it's hard to follow what Olivia and Brittany have already presented on. I mean, what can I add to that? It's already just a fantastic presentation. Just shows how fortunate I am at DeafLEAD to have such amazing employees that work with me. Something to add that I think is critical is that typically hearing organizations will be provided funding in order to provide services to marginalized populations, people who need services. So typically, hearing organizations receive funds in order to set up videophone services, if you will. So what's unique about our situation, what DeafLEAD finds ourselves in, is that we have a deaf-run, deaf-led organization where deaf individuals are the ones making decisions about services that we receive for our community. And that's something that's amazing. It's so important to be able to have that say for what we need. And I'll add another thing as well. Really, it kind of flips the script, if you will. So, like I said earlier, we're a deaf organization, and typically, when it comes to a deaf organization, we are in need of funding. Most deaf organizations we've seen for the past few years, over the past decades, have had to shut their doors just because funding was not available. It's not something that's continued. And that's what happens to marginalized populations whenever funding gets cut. Oftentimes it's the marginalized communities who are the ones that suffer the brunt of that. So since 2012 at DeafLEAD, we've been able to provide chat and text services here uh, for the deaf community, for deaf victims of crime. We've already been providing text services. And so Vibrant reached out to our organization just to talk about the chat and text services that we were able to provide, maybe providing some support, developing a relationship for that. So I learned a little bit more about the chat and text services that were developed on their end over at Vibrant for 988 or Lifeline as it was at the time. And so I wrote for the contract to see if DeafLEAD would be at least considered to provide or be a service provider for the Lifeline. And we ended up getting it, which is remarkable. It's a deaf organization. We are the ones providing services that are traditionally provided by hearing service providers. And so on the chat and text service line, we have hearing and deaf people who are working in tandem. They're working together in order to provide chat and text services, not just for the state of Missouri, but nationwide as a backup center. And it's truly an honor that we have been equitable in this work. We have a seat at the table. We have a voice that's heard in the realm of crisis services. And I just wanted to add that it's truly been an honor to do that.
Dr. Logan, this is Megan. Just absolutely an honor to have you and your team on. You all just serve such an incredible gap that's been there for a very long time, and really isn't seen by the hearing community. Unfortunately, there's a lot of things not seen by the hearing community, and this is the undercurrent of this is so huge. It's just huge. And so just thank you. Thank you. Thank you. And I want to bring on Michelle Niehaus, who is Program Administrator for Deaf and Hard of Hearing Services for the Kentucky Division of Mental Health. Michelle, I would love your perspective, on this. I know you're just an incredible leader as well.
Hello, thank you so much for the honor of being here today. And I just want to thank Crisis Jam and you, Megan, for being such leaders and such advocates in this space, always trying to think about who is not at the table. And I was thinking about Dr. Logan's comments and thinking about when I entered the field in the 90s, we thought about services for deaf people. And then we thought we were great when we moved to with deaf or hard of hearing people. And now we're seeing organizations like DeafLEAD doing more things by deaf leaders, and Dr. Logan leading the way for 30 years in that space. And even though we've been doing this for many, many years, we think about Crisis Jam as being one of the few places where access is a given. Most of the time, people have to fight for getting any kind of access whatsoever. The early video talked about not leaving anyone behind. And that makes me think about Olivia's comments around choice. We have to be thinking about whether a person wants crisis services in chat, if they want them through Videophone, if they want them in person, or if they want them virtually. And one of the earlier things talked about, 80% of these issues can be resolved through a connection. The connection is what most of the folks we see lack. There's so much isolation among people who are deaf and use sign language across the country, and there are very few specialized services. So we need to create more deaf spaces and prioritize direct services. Even in times when funding is being limited, we have to think about our budgets as a values-based document and think about how we want to move forward to create these opportunities that are really where people can build trust and get the services and supports that they need. I think about 40,000 calls in 2 years. How many of those folks are getting the follow-up services they need as well? So for everyone on this call, we have the opportunity to think about how are we partnering with deaf communities? How are we partnering with deaf professionals? And how are we making sure that we're not doing for, but we are letting and stepping back so that people who are deaf are taking the lead in doing that work. We need to change the paradigm, and I think we're in the process of doing that. We know that the needs are out there. Telehealth offers opportunities for direct communication, but we also have way more we can do in the crisis continuum. So I just think about watching DeafLEAD as the model for that nationally and what we can do together.
Michelle, thank you so much. And Michelle is one of 8 or 9 state coordinators of deaf mental health services that are identified within the Department of Mental Health. And however you want to say that in the state, that there are, different ways of saying it. But the key there, and one of the next steps for in the crisis system for people who are deaf, or serving people who are deaf, is to have those state coordinators in states, that there is a contact person who understands deaf culture, that understands ASL fluent, in touch with the deaf community to find out what is best, for them, and an advocate as well as coordinating services. And not all states have that. For DeafLEAD, they need to know, well, what is in each state in case somebody needs a higher level of care. And that next step is so important to prevent a higher level of response than what is necessary. So those state coordinators are so important. Michelle, thank you. And thank you so much for your leadership.
Thank you so much.
And so I want to just move to the NASHPIT update, which happens, I'm calling on myself because this subject matter is so important. I just want to emphasize the piece around video relay services and what Olivia and Brittany were noting. Direct services is actually the most efficient way to provide services. If you, for example, provide a hearing therapist and then an interpreter, you're actually paying more funding for that interpreting service. No bad against interpreters. This is just more about how it can work most efficiently. If you have an interpreter and a therapist, you're actually paying almost double. So having a therapist or caseworker that is ASL fluent and provides a direct service to the person who is deaf is the most funding efficiency, as well as the connection, as well as the communication. Super important to do that. And so again, want to encourage having state coordinators of deaf mental health services if possible. And Olivia is offering to be available for any questions or conversations after this. But I just want to emphasize the importance that actually providing direct services is part of being trauma informed. People who are deaf experience the isolation in a hearing world all the time. It is cumulative trauma in terms of people not seeing them, not understanding, thinking that ASL is English on the hands, just sort of misunderstanding how important it is. ASL has its own idioms, its own way of expressing, as Brittany was talking about and Olivia was talking about. It is the intensity of a sign, the way that it's signed, the emotions on the face, all show the emphasis and the emotion behind it. So I just want to note the importance of that cultural piece, that communication piece, that really helps everybody. So I also, so Michelle Niehaus is also giving a shout out to Kelly Sterling, who is the Georgia state coordinator. There may be other state coordinators on. Both Michelle and Kelly are absolutely wonderful in terms of their leadership. So thank you to those state mental health commissioners as well for supporting their leadership. So we are going to move on, and we will continue to have this conversation. And I just want to thank DeafLEAD for being on, and the interpreting team, everybody. Thank you for being on. We are going to move to the crisis jam. Okay, I am going to move this to Vibrant, Daniel and Catherine, I think it is. So.
Yes, thank you, Megan. And just want to say thank you to our presenters earlier. That was a fantastic presentation. I do want to provide a couple brief state updates. As you can see on the map here, this shows various ways that states across the country are funding 988. States that you see are yellow are states that have enacted a telecom fee for sustainable funding. And those that are in green are states that have annual appropriations from their state revenue sources to fund 988. And then finally, those white states are states that currently have pending fee legislation. Right now, there are 37 states that are currently in active legislative session. So lots of things to be tracking across the country. Just a few bills that I'd briefly like to highlight. Down in Texas, there is a bill in the House Bill 5342, which establishes a 988 trust fund and authorizes the commission to impose a fee on telecom services to fund 988. That bill had a public hearing a couple weeks ago on April 14th, and it was subsequently passed out of committee with a favorable recommendation. There weren't any committee substitutes or amendments in the committee, but we may see a floor amendment come from the sponsor that would amend the language to change it to require a study, to basically a study on the fee prior to a fee actually being created. There's also a similar bill. It's not quite a companion, but it's really close. In the Senate, SB 188. It's currently in the Senate Health and Human Services Committee, but it's not yet had a hearing. Now I'm going to move to Alaska. Alaska House Bill 138 is a 988 fee bill. It establishes the trust fund, or a separate account rather, and then also a 98-cent per month telecom fee. That bill basically it has three committees in the House that it has to hop through. It's currently in the House Health and Social Services Committee, and it has its first public hearing tomorrow. So that's something to keep an eye out for. And then also in Colorado, and I believe we shared this a couple weeks ago, but Colorado's SB 25236 consolidates Colorado's state legacy crisis hotline and consolidates it with 988. So all of the calls will be directed straight into the 988 system. It also updates student ID cards and other instructions to reference 988 instead. And it also shifts funding. That bill passed through the legislature on April 16th and is now pending the governor's signature. And with that, I'll hand it over to Catherine from NAMI to share a couple more.
Thanks, Daniel. Just two more updates for y'all. New Mexico is now gold or yellow on the map. Their General Assembly has passed a 988 fee bill, Senate Bill 535. This bill creates a new 988 fund, and also it increases an existing telecommunications surcharge from 0.33% to 1.66%, with 80% of that increase going to 988. So it is a percent of a percent, but they're anticipating it to bring in 3.6 million in the first year for 988. And then Maryland last year already passed a 25-cent fee bill, but this year the General Assembly also passed companion bills, Senate Bill 36 and House Bill 421. to authorize use of the 911 Trust Fund for operation and coordination between 911 and 988, including software and joint training. That's all we have for you today. Thank you.
Well, thank you so much. And let's see. I do want to just note that by population, Utah provides incredible amount of funding for each person. I just want to note that. I know we're kind of running out of time, but it's quite amazing. So Utah provides $10, almost $11 per person, and California provides $1.40. And you can see that California is part of the 988 fee legislation, but with that recurring appropriation in Utah, that that incredible work and amount. Now, we always want to support the fee and the appropriation, but it is amazing how Utah has just done excellent work with the Huntsman Crisis Center, for example. All right. And let's go to Stephanie Hepburn on 911 988 interoperability requires improved tracking and federal framework. Now, Stephanie Hepburn really writes the Crisis Talk article. And Stephanie, you're just an incredible writer, and you just really make things easy to understand. Can you tell us about what you wrote and what this article is about?
So it really started on March 5th. Richard McKeon, during the SAMHSA segment, had talked about two documents. One was SAMHSA released an educational guidance for healthcare providers. And he noted that NENA, which is the National Emergency Number Association, released a complementary document that really talked about 911, 988 interoperability. So I talk about that in the article, but I also wanted to know, well, what's the figure that can actually be diverted? And I'd written a great deal in anticipation of 988 about what this number would look like or potentially could look like. The Vera Institute had done a study, and they estimated around 20% of 911 calls could involve a behavioral health issue. And so potentially that would mean 20% of 911 calls could be diverted. And I wanted to see if maybe that figure had been updated, if there had been some research that gave us more precise figures. And the best that I could find were mobile crisis being able to divert, whether they are on the call center floor. So what did that look like? And those percentages, again, there's just like no centralized way to get this data. So when we look at 911 numbers, I wondered if there had been a shift towards that data being centralized. It hasn't yet. So again, the best I can do is look at mobile crisis diversion or crisis call centers that are diverting those calls on the call center floor. And those numbers range between 1% and 4%, depending on the community. So I think what this really pushes is when I've spoken to mobile crisis providers and call center diversion groups, what they've said is that's the best that they can give because they don't actually know what the entire umbrella is. And part of that is like even the call codes are not standardized. So it would be great. I think what we really need is a federal framework. We also have Next Gen 911 that is slowly rolling out throughout the United States. It seems like that would be a great opportunity in conjunction with the federal framework to be able to get a centralized database so we can actually know what that figure is and really maximize the potential of 988. And so that's what I was really focused on in the article.
That is really interesting, especially with 911 being more of a local implementation, right? How do you really bring all that together, and having that national framework just sounds like a great idea. So thank you so much, Stephanie.
Thanks, Megan.
Great. And so just want to highlight that episode 215 next week is a fireside chat on real men and suicide. And so Eric Hipple will talk about his experience with his son, who he lost to suicide. A very moving story. So we hope that you join us for that kind of fireside chat. And the episode 216 is a day in the life of crisis care part 1, someone to contact. So Sherry Sinwelski is now with DD Hirsch and used to be with Vibrant, and actually the National Suicide Prevention Lifeline. And Rachel will also be there. So there'll be, what's a day like as a crisis, contact center. So very, very cool. Want to thank everybody for joining today. What an incredible presentation, very informative. I always learn more. Thank you to the Crisis Jam. Thank you for all of the support, and to the presenters and the great work being done here. So everybody have a great rest of your week and take care.